Hello, good morning, friends. Well, we spoke about the blood pressure, the definition of blood pressure, then we spoke about hypertension. Well, now let's talk about the ways how you can measure blood pressure and why do we need to measure blood pressure? Well, it is evident that control of blood pressure over the full 24 hours period, particularly during the risky early morning period, is not being achieved in general practice. So now, what are the methods with which you can measure the blood pressure? Well, you have two types of blood pressure monitoring. First is the clinic blood pressure monitoring, which is also called as CBPM, and you have the 24 hours ambulatory blood pressure monitoring, which is ABPM. Well, there are limitations in the accuracy due to the presence of 24-hour BP variability and white coat or the masked hypertension. So CBPM might not be giving you the actual correct reading of blood pressure. So there are limitations, so we need to overcome these limitations, and an accurate and a reproducible tool for assessment and management of hypertension is definitely ABPM. Various out-of-office data can be obtained during morning, daytime, nighttime, and average 24 hours blood pressure. So ABPM is the tool for assessment and management of hypertension. Well, what does ABPM detect? Well, ABPM detects masked hypertension, excessive blood pressure reduction, early morning hypertension. It measures excessive BP variability, as well as it measures the fluctuations in the blood pressure. Well, with the help of ABPM, you come to know about the target organ damage, the mortality, the cardiovascular outcomes, the morbidity, and the prognosis of the patient who is suffering from high blood pressures. Now, how do you assess the efficacy of a drug which is there to reduce the hypertension or to bring down the high blood pressures? Well, that is called as the antihypertensive efficacy of the drug. Well, it correlates with hypertension associated target organ damage first, then smooth 24-hour blood pressure control even during the early morning period. Then your drug should have a high index of homogeneity of blood pressure reduction. Well, there should not be much fluctuations in the blood pressure. That is when the tablet is taken till the morning hours. So it should have a smooth blood pressure control even during the morning hours. Next, well, it is an assessment tool for the favorable effect of antihypertensive therapy. Well, regression of left ventricular hypertrophy can also be assessed with the help of these antihypertensive drugs. Next, it can be a tool for comparing the quality of blood pressure lowering with different antihypertensive drugs. So it is just for comparison whether a beta blocker is better controlling the blood pressure, or is it your ARB controlling better, or is it the calcium channel blockers. So it is an effective tool to compare the quality of blood pressure lowering with different antihypertensive agents. Then we have a smoothness index, which means it is an index of homogeneity, as I have explained in my previous discussion. Well, increase in the smoothness index implies a more smooth and a sustained antihypertensive effect. It implies that the drug which has smoothness index on the higher side or which is nearing 1, then definitely that drug is a better drug and is more suitable drug for control of blood pressure. Now it assesses the 24-hour blood pressure reduction and its distribution pattern throughout the 24-hour period. So a drug which has least variations or fluctuations will be an ideal drug, an ideal antihypertensive drug. So these are this slide highlights about the JNC 8 guidelines. It mentions about what is threshold blood pressure and what is the goal or the target blood pressure. Well, for the ease of learning, I have differentiated the two. When you talk about the threshold blood pressure or specific blood pressure thresholds, then it is the treatment BP or the blood pressure at which the treatment should be started to a patient. And after giving an antihypertensive drug, you achieve a certain target or a goal. So that is the goal or the target blood pressure. Well, it can also be termed as the treated blood pressure. That is what you achieve after a patient has been given this drug. So I hope I have made it clear the differences between threshold blood pressure and the goal or the target blood pressure. So our medicine, when given, will give you a reading of a goal or the target or the treated blood pressure. So pharmacological treatment and the drug classes. Well, we'll talk about the different drugs which are available. Well, as you are aware of, it's the first 4 letters of the alphabet, and it is again for the ease of learning: A, B, C and D. Well, A stands for ACE inhibitors and angiotensin II receptor blockers. Then B stands for beta blockers, C stands for calcium channel blockers, and D for diuretics. Now, what are the different modes of actions? What are the disadvantages of these different classes of drug? Now, that's what we are going to talk about. Well, the ACE inhibitors are also termed as angiotensin converting enzyme inhibitors or blockers. They inhibit the ACE enzyme which is involved in the angiotensin II formation. Hence, they cause a vasodilation which finally reduces your blood pressure. Well, the disadvantage is it causes breakdown of bradykinin, is also inhibited, and which can lead to an incidence of cough. Now coming to the next group, that is the angiotensin II receptor blockers. These inhibit the action of angiotensin II at the AT1 receptors, hence cause vasodilation and finally lowering in the blood pressure. Well, no major disadvantages have been reported so far. Then you have the next group, which is called the diuretic group. Well, these drugs, the mode of action, they increase fluid and sodium elimination. That means sodium and fluid moves out of the body. They reduce the venous return to the heart, hence they reduce the cardiac output and finally lower the blood pressure. At times, these drugs cause dehydration, electrolyte imbalance and hyperuricemia. Next, we have the beta blockers. Well, beta blockers, they block the beta 1 receptors in the heart, and thus they reduce the cardiac output, reduce the heart rate, and thus reduce your blood pressure. The disadvantages of beta blockers are they also act on the beta 2 receptors which are there in the bronchioles. Well, when the bronchioles are basically blocked, then or the beta 2 receptors in the bronchioles are blocked, then it will cause bronchoconstriction, which means narrowing of your air pipes. Bronchus is the air pipe, and when you are giving a beta 2 receptor, when you are giving a beta receptor which is not selective, then if it gets blocked, then you will have narrowing, which means suppose your opening of your bronchus was this big. After giving a non-selective beta blocker, the opening or the lumen of the bronchus is reduced. So this is called as bronchoconstriction, and this is not suitable to asthmatics, COPD patients and smokers. Asthmatics, because they have an inherent disease where they can't take in enough oxygens, or their bronchi, they go into a state of spasm. Then chronic obstructive pulmonary disease, again there is an obstruction due to the mucus or other inherent disorders inside the bronchi. So again you have a failure of you can say passage of enough air inside the bronchi, inside the lungs. So they are again contraindicated there. Then again it is in the smokers, because they also have bronchoconstriction because of excessive mucus production, or it may be the damage to the lining inside. So again it is contraindicated in smokers. So beta blockers, you have to use non-selective beta blockers, I will again highlight, are, I'll say, should be used with precaution in patients who have asthma, who have COPD and who are smokers. Then come your calcium channel blockers. Now they inhibit the migration of extracellular calcium into the intracellular fluid. So there is low intracellular calcium concentration. This causes vasodilation, and further this causes a lowering of the blood pressure. Well, the major limitation of calcium channel blockers has been fetal edema and water retention. Now we go on to the JNC7 classifications of blood pressure. Well, the patients can be classified into normotensive, who are in the pre-hypertension stage. Then you have the patient with stage 1 hypertension, stage 2 hypertension. So there are readings like for the systolic blood pressure. When a patient is considered normotensive, when the blood pressure, systolic blood pressure is less than 120 millimeters of mercury, and the diastolic blood pressure is equal to or less than 80 millimeters of mercury. A stage which is called as pre-hypertension stage is when a patient has a systolic blood pressure of 120 to 139 millimeters of mercury to 80 to 89 millimeters of mercury. Now we go on adding 19 to the systolic blood pressure readings, and diastolic, and on the diastolic component we add 9, and we will get a reading which will match the stage. So for stage 1 hypertension, the reading is 150 to 159. So you to 140 you have added 19, so you get 159. The range is from 140 to 159. The next is 90 to 99, you have added 9. Then this, in the stage 2 hypertension, you have blood pressures more than or equal to 160. As well, the diastolic blood pressure is more than or equal to 100 millimeters of mercury. So these were the classification as per the JNC 7 guidelines. Well, we have one more guideline which has come out recently. It is called as a JNC 8 guidelines. Well, we'll be talking about that also in detail. So yeah, now we have the JNC 8 guidelines. So what was the JNC 8 guideline highlighting? Well, in the JNC 8 guidelines, well, it was, first of all, I must highlight that it was based on evidence-based medicine, and the 3 highest ranked questions related to blood pressure management were identified. Well, all this guideline was, the background of it was on the basis of the RCT, that is randomized controlled trials in adult hypertensive patients. The first question which was ranked as priority basis was when to initiate the treatment. Second is, and that is the specific blood pressure threshold or the treatment blood pressure, that is you need to identify that. Then second is the treatment part of it. When you are treating the patient, what is the specific blood pressure goal or the target BP which you need to achieve, and which drug is offering more benefit or which is having more harm, which is causing more harm to the patient. So we need to decide according to the class of the antihypertensive which has to be given to a particular group of patients. So but the results was improvement in the health outcomes, and that too in the mortality rates. So this was in brief about your JNC 8 guidelines. Well, there are different protocols. We won't go into the details at the moment. But what I want to focus is now what are the guidelines they have mentioned for achieving those goal BPs. Well, for patients who are aged more than 60 years, the blood pressure goal should be systolic of less than 150 millimeters of mercury, and diastolic should be less than 90 millimeters of mercury. For patients who age less than 60 years, the blood pressure goal should be 140 and 90 millimeters of mercury. All ages, diabetic patients who present with the no CKD, their blood pressure goal should be 140, less than 140, less than 90. All ages CKD patients who present with or without diabetes, the blood pressure goal should be systolic 100 less than 140, diastolic less than 90. Then the JNC 8 guideline, it talks about how to select a drug for treatment titration strategy. Well, this talks about which is the how do you start the treatment of a patient with hypertension. First, what they consider, maximize first medication before adding the second. So they talk about that you keep on increasing the dose of the single medicine and then add the second. Or another possibility, add the second medication before reaching the maximum dose of the first medication. So you need not go up to the maximum limit, you can add on in between, or start with 2 medication of different classes, or as a fixed dose combination. So all these possibilities are there for managing blood pressure nowadays according to the JNC 8 guidelines.